يا دكتورة ريم جربي انت. I'm not sure this.
So, dear attendees, one more minute and we're gonna start our event today. So, hello everyone. I would like to welcome you to our third IVPN Oncology Educational Series in 2022. Today we are honored to have Dr. Mahrouz with us as our moderator and Dr. Reem as our speaker. Together in the coming 45 to 1 hour, we're gonna discuss about the asparaginase-based therapy in acute lymphoblastic leukemia patients. It is a specialized topic in which we're gonna talk about use of specific medication in a specific type of cancer patients. Mainly, we're gonna emphasize about the pediatric populations, as well as we're gonna have some application in the adult population as well. With no further delay, I want to thank Dr. Osama Tabbara, as well as for the operations team, as well for the oncology organizing committee for giving us this platform to share our experience with you as a colleagues all over the Middle East region. So with no further delay, it's my honor to introduce a dear friend and one of the important oncology team members in the listserv, as well as an editor in the Oncolight listserv, Dr. Muhammad Mahrouz. So Dr. Mahrouz earned his bachelor degree of pharmacy in 2009 from the Pharmacy Zakazek University in Egypt. He started his career in Tanta Cancer Center in October 2009 as an oncology pharmacist. From this date till March 2018, he took several positions in different regions as an oncology pharmacist in IV mixing, as well as a hematology oncology clinical pharmacist, as well as medical coordinator of quality team in Tanta Cancer Center. Since 2018, he joined Dar al Fuad Hospital as a senior clinical oncology BMT pharmacist till May 2019. After that, he joined Oncology and Nuclear Medicine unit in Egypt Air Hospital to establish oncology clinical pharmacy system there from May 2019 until now. He earned his master's degree in oncology clinical pharmacy from Tanta University in July 2021. He published many scientific articles and posters between 2019 and 2021 as an Excellence in Oncology Conference in UAE, as well as NCCN Annual Meeting 2020 as a poster presentation, as well as original research article for his master's degree in the cancer chemotherapy and pharmacology journal article. Dr. Mahrouz, we are so honored to have you with us. You are a very dear friend as well as an amazing colleague. I leave the area for you. The floor and the mic is yours.
Thank you, Dr. Fatma. Really appreciate it, and thank you for good introduction. You are really a good friend and a good leader also. Please welcome with me with Dr. Reem Hal. She graduated from Faculty of Pharmacy, Alexandria University, class 2018. She is a senior pediatric oncology pharmacy in Burj Al Arab Main Hospital, Alexandria University in Alexandria. As a senior clinical pharmacist, her role was the key person between the physicians and nurses to adjust the right drug dose and duration of therapy. Also, one of her greatest achievement, I think, is the establishment of antimicrobial stewardship program in the hospital. Also, we are honored to have Dr. Reem in our IVPN oncology listserv and pharmacogenomic listserv. So, Dr. Reem, welcome on board. The mic is yours.
Welcome, Dr. Mohammed Mahrous. Thank you for your nice words and nice introduction. And I'd like to thank also Dr. Fatima and Dr. Osama Tabara for this kind invitation for this educational series. So let's start with our presentation. So today our topic will be based on the asparaginase-based therapy in acute lymphoblastic leukemia patients. Our learning objectives is among these 4 points. Number 1, to discuss the efficacy of asparaginase by the serum asparaginase activity and how this efficacy is affected by toxicities resistance. And number 2, to discuss the management of various drug-drug interactions and to discuss the management of asparaginase toxicities. And number 4, to discuss some pediatric secrets concerning asparaginase. These words I'm highlighting with the red color are mainly the 4 points we are going to conclude at the end of these slides. So this is a disclosure that I declare to the meeting attendees that there are no financial relationships with any for-profit companies that are directly or indirectly related to the subject of my presentation. So first of all, let's talk about the asparaginase itself. As we all know that asparaginase word or the end of ase means an enzyme. So it is an enzyme isolated from the bacterium Escherichia coli or the bacterium Erwinia carnivora or chrysanthemi with antileukemic activity, which results in, number 1, the protein synthesis inhibition, number 2, cell cycle arrest in G1 phase, which ends with the apoptosis of the cell. So the mechanism of action of asparaginase, we are mainly going to talk about 2 main points, according the asparagine synthase, and number 2, according to the glutamine. So the tumor cells lack asparagine synthase and thus require exogenous sources of L-asparagine. On the other hand, the natural cells or the human cells possess the asparagine synthase enzyme. So L-asparaginase hydrolyzes the circulating L-asparagine to aspartic acid and ammonia. And at the end of the slides, we will find that one of the major side effects of the asparaginase is the hyperammonemia. So killing ALL cells, but not normal cells that can make their own asparagine by their own asparagine synthetase, which acts as a protector for the normal cells. And then depletion of the essential amino acid L-asparagine results in rapid inhibition of the protein synthesis. On the other hand, L-asparaginase also deaminates glutamine to glutamic acid, which decreases the glutamine levels in the circulation. The glutamine is mainly the main nitrogen donor for the synthesis of RNA and DNA by the tumor cells, and hence its depletion helps the tumor growth and enhances the cell apoptosis. So the cytotoxicity of the drug correlates with inhibition of the protein synthesis. This diagram is to summarize what we have mentioned before, that the normal cell possesses its own asparagine synthetase. That's why it protects its own survival. While on the other hand, the tumor cell lacks the asparagine synthetase, so it cannot protect itself against the asparaginase, which results at the end to the tumor cell death. On the other hand, this diagram, by measuring both the asparagine and the glutamine, so asparaginase hydrolyzes the asparaginase into aspartic acid and ammonia, and it deaminates the glutamine into glutamic acid, results in the cell apoptosis. Okay, let's talk on the mechanism of resistance of asparaginase. First of all, increased expression of the L-asparagine synthetase gene, which facilitates the cellular production of L-asparagine from endogenous sources. Number two, upregulation of asparaginase synthetase expression in leukemic cells in asparagine-depleted environment. Number three, increased substrates for the asparagine synthetase reaction in leukemic cells. Number four, formation of antibodies against the L-asparaginase, resulting in inhibition of function. Influence on the protein synthesis and apoptosis in the leukemic cells, overexpression of the BCL2L13, one of the genes associated with the asparaginase resistance, and at the end, host factors. So, host factors like bone marrow microenvironment, as the bone marrow mesenchymal cells express significantly higher amounts of asparagine synthetase than leukemic cells. So they then showed that the resistance of leukemic cell lines and some specimens of primary leukemia to asparaginase is correlated with the expression of asparagine synthetase by the mesenchymal cells. And the increased expression of asparagine synthetase by the mesenchymal cells lead to increased resistance of the ALL cells and vice versa. Number two, the obesity, as it is believed that glutamine synthetase expression was markedly increased in the bone marrow adipocytes. Adipocytes protected acute lymphoblastic leukemia cells from asparaginase treatment via the release of the glutamine, which is believed to be the nitrogen donor for RNA and DNA synthesis for the leukemia cells. At the end, the pharmacogenomics point of view as a single nucleotide polymorphism in the promoter region in asparagine synthetase gene on the site 92 guanine instead of adenosine is associated with increased asparagine synthetase expression, and it is more common in pediatric leukemia patients. Okay, let's talk about some of the asparaginase products. So, pegylated asparaginase is currently considered the frontline standard of care for ALL treatment in North America and Western Europe. But nowadays, after the 2018, maybe it is replaced by the cal-asparagase pegol in the coming years due to improved product stability. While Erwinia products are currently second-line therapy used following allergic reaction to peg-asparagase or cal-asparagase pegol. The risk of other toxicities is common to both E. coli and Erwinia asparaginase products, so switching asparaginase products does not impact toxicity risk. So we have different four forms of the asparaginases, whether to be E. coli derived or Erwinia or pegylated by the polyethylene glycol to native E. coli asparaginase or the cal-asparagase pegol. So this table is to differentiate between the results versus E. coli asparaginase versus Erwinia asparaginase. Looking to the CR or the complete remission not reached in the Erwinia, which was higher than in E. coli, and the remission failure, which was also in Erwinia higher than the E. coli. So this gives the privilege to the E. coli asparaginase and giving the Erwinia asparaginase only the second chance in case of hypersensitivity or inavailability. Number three, the pegylated asparaginase, polyethylene glycol asparaginase is a conjugate of the native E. coli asparaginase, which is covalently linked to the PEG at sites not affecting the enzyme activity. Number four, the cal-asparagase, which is derived by adding the PEG moiety, polyethylene glycol moiety, to E. coli native asparaginase using more stable succinimidyl carbonate linkage. So, looking forward to the pharmaceutical point of view, how do we prepare asparaginase? We look first on the reconstitution of the vial itself. So, according to the E. coli asparaginase, we will reconstitute the vial with 4 milli sterile water for injection, resulting in a factor of 2,500 per milli. While regarding the Erwinia asparaginase, we will reconstitute the vial the 10,000 international unit vial with preservative-free normal saline to obtain the factor of 5,000 per milli. Pegylated and cal asparagase are ready-made. Looking forward to the further dilution, most probably for the 4 regimens or for 4 formulations, 100 milli normal saline is the most appropriate dilution form, while the E. coli has a wider range from 52 to 150. The rate also most probably for the 4 drugs for around or over 1 hour, but if infusion-related reactions took place, so we can extend the infusion to be over 2 hours. The product stability for E. coli is 3 hours, while for the Erwinia is for 4 hours, and to pegylated or cal asparagase is for 48 hours. The main comment for the 4 formulations is not to shake the preparations. Okay. Switching preparations, as we have mentioned before, that maybe due to the inavailability or the hypersensitivity, we can shift to the Erwinia asparaginase. So, pegylated asparaginase 2,500 international unit per meter square every other week is equal to Erwinia asparaginase, whether 2,000 international unit thrice weekly or 30,000 international unit per meter square twice weekly. Will result in 6,000 international unit per meter square every week. And in other dosages, pegylated asparaginase 3,000 international unit is equivalent to 36,000 international unit Erwinia twice weekly. And in case of 3,500 international units, which is equivalent to 42,000 international units. Okay, so to maintain the activity of the Erwinia level or any other asparaginase, we should measure the enzymatic activity of the asparaginase to reach the 0.1 international unit, which is the lowest activity of the asparaginase in the blood or in the plasma. So 0.1 international unit per milli is required to fully deplete the plasma asparagine to be less than 0.1 millimole per liter, as the normal asparagine level are around 65 millimole per liter. For the past decade, FDA approval of asparaginase products has been based on the nadir serum asparaginase activity levels to be more than or equal 0.1 international units per milli. The nadir has been defined as 14 days for pegylated products and 48 or 72 hours for the non-pegylated products. So, we recommend the testing of serum asparaginase activity level after the first dose of pegylated asparaginase, and this should be done within 7 days of the dose. If the level is detectable but less than 0.1, activity should be rechecked at day 14. Pre-existing antibodies may lead to lower the peak serum asparaginase activity levels, but did not increase the rate of the non-therapeutic levels. So if 2 consecutive levels are undetectable, then switch to another formulation, which is Erwinia, for example. So when should patients be screened for silent inactivation? Silent inactivation of E. coli-derived asparaginases has been reported in the induction and the intensification phases. Some patients may have developed antibodies to the polyethylene glycol before the start of PEG asparagase, which is mainly maybe due to the polyethylene glycol molecule itself rather than the asparaginase molecule, due to previous exposure to polyethylene glycol, for example, in the creams. So, the silent inactivation is caused by neutralizing anti-drug antibodies to the asparaginase or the polyethylene glycol, resulting in asparaginase inactivity without the development of overt allergy symptoms. So it can be identified with trough asparaginase activity levels below the lower limit of quantification, occurring in patients without clinical allergy, preferably measured in 2 independent samples to minimize the number of patients tested false positive. In addition, low activity levels should always be interpreted in the context of the dosing and frequency of the administration of asparaginase. For example, with the use of Erwinia asparaginase based on large inter-individual differences in clearance, low trough levels at 72 hours and beyond could reflect a need for more frequent dosing. For our knowledge, we can increase the frequency of dosages of asparaginases by the least interval is spacing by 48 hours. And this can be found or this can be applied if the serum activity is less than 0.1 international unit per milli. So this may be rather than the silent inactivation itself. So silent inactivation of asparaginase, according to the PEG asparagase, given every 2 weeks, a day 7 asparaginase activity level below 0.1, this can be mentioned as a silent inactivation. And concerning the E. coli asparaginase, if the 72 hours post-dose level is below the LLQ in a 2 times a week schedule, so it is a silent inactivation. And regarding the Erwinia asparaginase, which is 3 times a week schedule, a 48 hours post-dose level would raise the concern for silent inactivation. Okay. Let's go to the drug interactions. Mainly, I have 3 drug interactions with the asparaginase, or the 3 major drug interactions with asparaginase. First one with the methotrexate. L-asparaginase can inhibit the cytotoxic effect of the methotrexate, so 24 hours spacing is much preferable. While regarding the triple intrathecal as the dose of methotrexate, the highest dose of methotrexate in the intrathecal is 12 milligram or 15 milligram, which is a very, very small dose. So asparaginase treatment should be delayed only until at least 2 hours after the intrathecal treatment. At the end, the vincristin L-asparaginase inhibits the clearance of vincristin, resulting in increasing the host toxicity and pancreatitis and the neurotoxicity. So it should be administered 12 to 24 hours before the asparaginase. Okay. Concerning the polyethylene glycol asparaginase toxicities, we do have main 5 toxicities: hypersensitivity, thrombosis, pancreatitis, and hyperammonemia and hepatotoxicity. So let's start with the hypersensitivity. Asparaginase hypersensitivity, many hypersensitivity or allergic reactions to asparaginase are classic acute hypersensitivity with wheezing, dyspnea, and angioedema or diffuse urticarial rash. Most commonly occurs with the second exposure to asparaginase. Infusion-related reactions are generally less dramatic and may occur with any exposure and may not impact asparagine depletion. The management is mainly to use diphenhydramine, but we can prevent the hypersensitivity. First of all, we can give or extend the infusion to be over 2 hours rather than 1 hour. Number 2, to pre-medicate before the pegylated asparaginase administration. So it is mandatory pre-medication with acetaminophen, hydrocortisone, and diphenhydramine decrease the rate of pegylated asparaginase hypersensitivity reactions to 4%. While in the pediatric population, we can use diphenhydramine famotidine, but hydrocortisone is only re-challenged in case of a prior reaction. Because in the pediatric population, we are afraid of sort of osteoporosis or immune suppression when we enter or when we give hydrocortisone. So we only give hydrocortisone in case of a prior reaction. Along with routine therapeutic drug monitoring, decreased rate of Erwinia substitution from 17 to 7%. As we have mentioned, that Erwinia is to be the second line. So it may be useful as primary or secondary prevention for reactions that do not involve anaphylaxis and are more similar to infusion reactions. Okay, the doses are to be, according to the acetaminophen, 1 gram pre-medication with pre-medicate with 30 minutes, for example. And according to the pediatrics, with 15 milligram per kg. according to the hydrocortisone meet milligram flat dose, while according to the pediatrics, the average is to give 5 milligram per kg, but never to forget that hydrocortisone is re-challenged after the prior reaction. Diphenhydramine or chlorpheniramine for 5 to 10 milligram, and here for pediatrics 0.1 milligram with a maximum 6 milligram, and famotidine is to give 1 milligram per kg by maximum 40 milligram. Okay. Asparaginase therapy is only stopped if a dose-limiting toxicity is happened, which is a hypersensitivity to E. coli-derived asparaginase, which can be replaced with an Erwinia asparaginase. While there are some limitations to the Erwinia asparaginase, first of all, switching asparaginase products will not overcome other toxicities such as pancreatitis. Number two, intermittent availability of Erwinia products over the past 20 to 30 years. Some patients will develop hypersensitivity to Erwinia as well, leading to complete cessation of asparaginase. These factors provide the opportunity to assess the clinical impact of asparaginase discontinuation or replacement of pegylated asparaginase with Erwinia. So, when changing asparaginase preparation, those receiving native E. coli asparaginase who develop clinical allergy or silent inactivation should switch to either PEG asparagase or Erwinia asparaginase. And most probably the best option is to be Erwinia asparaginase, as the pegylated is a conjugate to the E. coli native, with the choice of a second-line agent dependent upon the protocol specifications and the preparation availability. Patients initially receiving PEG asparagase may only be switched to the Erwinia asparaginase. Switching to the native E. coli asparaginase should not be considered an option. So, asparaginase activity monitoring after change in preparation to Erwinia asparaginase. Because Erwinia asparaginase is frequently dosed on Monday, Wednesday, Friday schedule, there may also be clinical value in checking a level at 72 hours after dosing, after the Friday dose, and before the following Monday dose. It may be reasonable to adjust dosing or interval to maintain the level greater than 0.1 international units per minute. So, the disease-free survival here regarding the Erwinia substitution versus those who received all asparaginase pegylated, most probably having the same disease-free survival. While those who have missed the asparaginase doses, they have decreased by 20%. So the disease-free survival has decreased by 20%. On the other hand, those who tolerated more than 26 weeks and those who didn't tolerate more than 26 and they took only less than 25 weeks, the 5-year event-free survival was much higher in those who tolerated by also 20%. So this was in the study of the Dana-Farber Cancer Institute 9101 for those who tolerated less than 26 versus those who tolerated more than 26 weeks for their planned 30-week treatment. Okay. In Dana-Farber Cancer Institute study, the 42 patients who developed an allergy to native E. coli asparaginase and switched to Erwinia asparaginase had outcomes similar to those 170 patients who received the all E. coli asparaginase doses. So, number two, in the asparaginase toxicity, the thrombosis or the thromboembolism. The pathogenesis, the exact pathogenesis of ALL-associated thromboembolism is unknown, but we do have some risk factors. Number one, concomitant administration of asparaginase and steroids. They are two important anti-leukemic agents and is shown to increase the risk of ALL-associated thromboembolism. Number two, if the age is more than or equal 10 years. Number three, the high-risk ALL patients, those who are less than 1 year, or those with DNA index less than 1 who have hypodiploidy, or those of a T ALL cell type or those who are having translocation in gene 4 and 11, chromosome 4 and 11. Number 4, certain inherited and acquired prothrombotic defects are known to contribute to the development of thromboembolism. That's why we should, as a baseline, do thrombophilic assay to the patients before the start or initiation of the asparaginase. The National Cancer Institute ALL studies reported around 10% incidence of thrombosis with significantly increased risk in older children more than 10 years and those with high-risk ALL, while the German investigators documented around 50% incidence of thromboembolism during therapy with concomitant asparaginase and steroids in children with at least one prothrombotic defect. Am I heard well, Dr. Mahrous?
Yes, doctor, everything is good. We're hearing you well.
Yes, you are doing well, doctor.
Okay. Thank you so much. Okay, asparaginase is thought to contribute to a hypercoagulable state through the disruption of the homeostatic balance with decreased production or secretion of native anticoagulant proteins like antithrombin, protein C, and protein S, while the effect of asparaginase actually is much more on the antithrombin. And the rates of thrombosis appear to be similar for pegylated and the native E. coli asparaginase in pediatric population. And the management, whether enoxaparin or antithrombin, the rates of vein thromboembolism between enoxaparin and antithrombin were not statistically different. So the duration for vein thromboembolism is around 10 days for therapeutic dose and prophylactic dose till the end of asparaginase treatment. And then as thrombosis or pulmonary embolism, therapeutic dose, and to stop only if platelets is between 30 or 50 according to your institutional guidelines. According to us, we stop it on the platelets when the platelets are 50. Okay, this is a diagram to summarize the effect of steroids and the effect of asparaginase on the coagulative properties. Steroids are found to induce factor 8 and prothrombin, and it also induces the plasminogen activator inhibitor, while it reduces the fibrinolytic proteins. This all results in the blood clot. On the other hand, the asparaginases causes the suppression of natural anticoagulants like antithrombin, protein C, or protein S. This also results in thrombin and a blood clot. Okay. Another diagram is that L-asparaginase-based therapy causes decline in protein C and S and antithrombin, and platelet activation, endothelial activation, and causes decline in the plasminogen level, causes thrombosis. And the other factor is the use of high-dose steroids, which leads to thrombosis as well. And the other risk factors that older age, as we have mentioned, that more than 10 years, older than 10 years old, central venous catheter, or high risk, such as T-cell phenotype, in boys much more than in girls, and non-O-blooded group, and the genetic thrombophilia. Those all are factors leading to thrombosis and thromboembolism asparagine induced. Okay, and this is the assay or the profile we should do for the patients before the initiation of L-asparaginase. So, prothrombin gene polymorphism, number 1, and the methylene tetrahydrofolate reductase, as this gene mutation 677 cytosine instead of thymine leads to thromboembolism in the general population. So what's about if it is in the patients who are receiving asparaginase? Also protein C and protein S and antithrombin deficiency. These are the main 4 genes we have to look for before the initiation of asparaginase. Okay, according to the treatment or concerning the treatment of asparaginase thromboembolism, we mainly use enoxaparin. Actually, I haven't used before antithrombin. Enoxaparin for adult dosing therapeutic 1 milligram every 12 hours, which is the preferred regimen, while for much better combined milligram per kg every 24 hours for 10 days, then prophylactic dose. And then the prophylaxis is to be between 40 to 60 milligram for international units every 12 hours. And concerning the pediatric population, the therapeutic dose is to be 1 milligram every 12 hours for 10 days, and then prophylactic dose is to be 0.5 milligram per kg every 12 hours. Concerning the antithrombin, we do have lab-directed dose or weight-directed dose. So the lab-directed dose is to achieve, first of all, 120% of the target levels for 2 to 8 days. And it has a special equation, which the desired antithrombin level percentage, which is 120, minus the baseline antithrombin level, which is measured right now on the lab test of the patient, minus the body weight, times the body weight, and divided by 1.4, giving the units of antithrombin required. On the other hand, the pediatric population, we do also have the same percentage, 120%, minus the baseline antithrombin level times the body weight divided by 1.4, giving us the units of antithrombin required. Or weight directed around 50%, 50 units per kg per dose as a single dose, but I do prefer the lab directed to be more accurate. Number 3, to go with the pancreatitis. Polyethylene glycol asparaginase toxicities pancreatitis, first of all, to assess the amylase lipase levels. Number 2, to do ultrasound abdomen if the pancreatitis is suspected, to discontinue polyethylene glycol asparaginase, and if pancreatitis is confirmed, do not resume the asparaginase. And in case of severe pancreatitis, we can give one of these 3 broad spectrum antibiotics. I'm sorry, we are running out of time, so I'll speed the slides. Number 4, the hyperammonemia or asparaginase blues. Immediate, it will be in the form of infusion reactions, and delayed, it will result in a fatigue. So if a patient is coming to your clinic and complaining of a fatigue, never underestimate this complaint. So we can give 3 drugs, whether lactulose or rifaximin or metronidazole, or we can give a combination of lactulose and rifaximin. Dose of lactulose, we can give the average dose of 16.7 gram in divided 2 to 3 doses, while the metronidazole is to be 250 milligram every 12 hours for 1 week. And concerning the rifaximin, if the disaccharide lactulose is not giving the appropriate response, so we can give one of these doses, either for 100 every 8 hours or 550 every 12 hours for a duration of 5 to 10 days. At the end, we will end with the hepatotoxicity induced from asparaginase. L-carnitine is found to reverse the pig asparaginase induced hepatotoxicity. The other dose is to be 1,000 divided every 3 hours and giving the maximum daily dose 3,000. While on the other hand, the pediatric dose, giving the loading dose, first dose 50 milligram per kg for the first dose, and then followed by the next 24 hours, 50 milligram per kg divided every 3 hours. Okay, concerning the hepatic dose modifications, the transaminases, if more than 5 to 20 times the upper limit, we can delay the next dose until the transaminases are less than 3 times the upper limit. While if the transaminases are more than 20 times the upper limit, we can discontinue therapy if it takes longer than 1 week for transaminases to return below the 3 times the upper limit. And concerning the direct bilirubin, if it is between 3.1 to 5 milligram per deciliter, we can hold asparaginase and resume only when the direct bilirubin is less than 2 milligram per deciliter. And consider switching to alternate asparaginase. And if the direct bilirubin is more than 5 milligram per deciliter, we can discontinue asparaginase and do not substitute other asparaginase products, and we can never compensate the missed doses. Okay, as a sum up for the asparaginase toxicities, first of all, the hypersensitivity, as we have mentioned, we can pre-medicate, but for steroids, only pre-medicate for pediatrics in case of prior event. And we can switch to Erwinia-derived for grade 3 positive allergy and monitor for asparaginase activity levels. Concerning the thrombosis, uncomplicated DVT, we can hold asparaginase and treat with appropriate antithrombotic therapy, as we have mentioned, through the enoxaparin for 10 days and for prophylactic dose for the rest of days remaining for the asparaginase treatment. And if it was severe or life-threatening thrombosis, so we should discontinue asparaginase permanently and treat with appropriate antithrombotic activity. Concerning the pancreatitis, we can hold asparaginase for elevations in lipase or amylase more than 3 times the upper limit until the enzyme levels stabilize or decline. And we can only discontinue in case of pancreatitis is confirmed by ultrasound. Concerning the hypertriglyceridemia, treatment depends on the severity, but may include fenofibrate or niacin or fish oils. And we can hold asparaginase only if more than 1,000 milligram per deciliter and close monitoring for pancreatitis. Some pediatric practice secrets. In case of pegylated asparaginase shortage, we can substitute with E. coli asparaginase by equivalent doses. So, induction phase, pegylated asparaginase is around 3,000 international units per meter square, which are substituted with 30,000 international units per meter square of E. coli. But because we cannot administer more than 10,000 in one time, so we divide the 30,000 international units per meter square on 6 doses to give 5,000 international units thrice weekly. Okay. Day 2 and 4 and 6 from day 1, and day 2 and 4 and 6 from day 8 for a total of 6 doses. While in case of MRD of day 15 is more than 1%, then another 30,000 international units are to be administered, but in a dose-dense protocol. So we can give it the 30 in 3 doses, 10,000 international units thrice weekly. Okay. In case of thromboembolic events during asparaginase treatment, enoxaparin is to be given with therapeutic dose for 10 days and prophylactic dose till the end of asparaginase treatment. In case of Down syndrome pediatric patients, unlike all other drugs given with 30% dose reduction, asparaginase is given with 20% dose reduction. Finally, with cal-asparagase pegol, Asparalis, cal-asparagase pegol can be considered in place of PEG asparaginase in patients less than or equal 21 years for more sustained asparaginase activity. So it is indicated in pediatric patients from 1 month to less than 21 years. NCCN recommends to consider using cal-asparagase in regimens that require significant numbers of asparaginase doses. This new product provides for a longer interval between doses. It's every 3 weeks, so it is better compliance and less invasiveness compared to other available PEG asparagase products. It is derived by adding polyethylene glycol moiety to E. coli asparaginase using more stable succinimidyl carbonate linker. And it has the FDA approval in 2018, not currently approved outside of the US. The dose is 2,500 units per meter square, if no more frequently than every 21 days. Recommended pre-medication to pre-medicate with acetaminophen, H1 blocker as diphenhydramine or chlorpheniramine, H2 receptor blocker as famotidine, and to be 30 to 60 minutes prior to administration to decrease risk and severity of both infusion and hypersensitivity reactions. The safety of Asparaginase was investigated in study of Dana-Farber Cancer Institute 11001, an open-label randomized active controlled multi-center clinical trial that treated 237 children and adolescents with a newly diagnosed ALL or lymphoblastic lymphoma with Asparaginase 2500 international unit per meter square versus pegylated asparagase 2500 international unit as part of Dana-Farber Cancer Institute. The median age on enrollment was 5 years, range between 1 year to 20 years, and most patients were considered standard risk. Okay, the median number of doses during the study was 11 doses for Asparaginase and 16 doses for pegylate. The median duration of exposure was 8 months, but only there was a fatal adverse reaction, multi-organ failure in the setting of chronic pancreatitis associated with a pancreatic cyst. The results here is that serum asparaginase activity was more than or equal 0.1 international unit per milli in more than 95% of patients on both arms 18 days after dosing. While at day 25, more patients had serum asparaginase activity more than or equal 0.1 international unit per milli with only cal asparagase, with 88% versus 17% for pegylated. And there were no differences in frequencies of asparaginase allergy or pancreatitis or thrombosis or hyperbilirubinemia. So they both have the same toxicity profile, but the cal asparagase is much better in the compliance and with less invasiveness. Okay, hepatic dose modifications regarding the cal asparagase bicol, hepatic impairment prior to treatment initiation. If it is mild to moderate impairment, there are no dose adjustments provided in the manufacturer's labeling, while in the severe impairment, use is contraindicated. While in case of hepatotoxicity during the treatment, total bilirubin, if more than 3 to 10 times upper limit, so we can withhold the cal asparagase bicol until total bilirubin levels decrease to less than 1.5 times. And if the total bilirubin is more than 10 times the upper limit, so we can discontinue cal asparagase bicol and do not make up for missed doses. Thank you so much. I hope I haven't missed the time.
Thank you, Dr. Reem, with this comprehensive and concise presentation.
Thank you, Doctor.
I'll start the poll questions, and then I will get your feedback.
Okay.
So our audience, please respond to these questions as a poll questions. Thank you. First question, the nadir value of PEG asparaginase has been defined as 14 days, 72 hours, 48 hours, or 7 days. Question number 2, vincristine should be spaced for asparaginase by 24 hours, 48 hours, 72 hours, or 1 week. Question number 3, if severe hypersensitivity from PEG asparaginase, we should shift to Escherichia coli asparaginase, Erwinia asparaginase, cal asparagase. Thank you. Waiting for your answers. Thank you. So, Dr. Reem, the first question, the nadir value of big asparaginase has been defined as. First answer was 27%. Second choice, 36%. Third choice, 18%, and also the fourth choice.
Actually, the answer is 14 days. I don't know why the people got puzzled. But I want you to remark it as pegylated makes the drug more sustainable. So pegylated equals 14 days to make it much more remarkable for you when you are studying. So the most correct answer is 14 days because the nadir is 14 days for the pegylated, while for the E. coli it is 72 hours. And in case of Erwinia, it is 48 hours. So I hope that the 36% at least would be 14 days.
Okay, thank you for your answer and your feedback. So let's move to second question. Vincristine should be spaced for asparaginase by. First answer was 64%. Second answer was 18%. Third and fourth were equally by 10%.
Yes, they are correct by spacing by 24 hours, or actually from 12 to 24 hours to reduce the incidence of pancreatitis and neurotoxicity enhanced by the asparaginase because it increases the level of the vincristine and increases the side effects. So actually 24 hours is right.
Okay, thank you. So the last question, question 3. If severe hypersensitivity from big asparaginase, shift to. First answer was 9%. Second answer was 55%. Third answer was 36%.
Yes, they are right. Also, Erwinia asparaginase is the most correct answer, as we only reserve the Erwinia asparaginase for the second line in case of hypersensitivity, inavailability, something like this. So Erwinia is also reserved, yeah.
Okay. So let's move to question and answers from our audience. Okay. First question from Dr. Muhammad Noor. Can you elaborate more about pharmacogenomic aspects that should be considered when receiving asparaginase therapy?
I can't understand the question. Would he clarify? Can you elaborate more about the pharmacogenetic aspect? Do you mean the thrombophilic assay before the beginning or before the initiation of the asparaginase?
I think this.
Can I understand? Oh, okay. We mainly follow or we mainly see the genetic mutations of the prothrombin time, and number 2, the MTHFR, the methylene tetrahydrofolate reductase, and the protein C and protein S. I want to know what is not clear in this slide. Let's go to the slide. Okay. What's not clear? Can we open the mic for him, Dr. Mahrous, or it is not allowed?
No, I think the mic is yours and me only.
Okay. Can you elaborate more?
So just elaborate the.
It's okay. We can
I can't understand the question. So we only know about the prothrombin gene polymorphism and the MTHFR polymorphism also, and the protein C and S and antithrombin deficiency. Mainly, these are the 4 aspects we are looking for.
Okay, thank you, doctor.
Thank you. Dr.
The
Mohammed
second,
Nagy
the
is,
second question from Dr. Muhammad
I'd like
Nagy.
to welcome Dr. Mohammed Nagy.
is
Head of
most
Let's
welcome.
Serve. Yes, he is the head of Let's
He is
Serve
most welcome here.
pharmacogenomics.
Is Big Aspara is available for patients with complicated DVT in Egypt?
No, I don't think so. I have no idea if pegylated Aspara is available in Egypt.
Okay.
Yes, but no, it is not used with complicated DVT. No.
Okay.
Complicated DVT, we always go to the Erwinia.
Great. Okay. Thank you, doctor.
Thank you.
I will change to some questions from our audience also. So how many minutes should we monitor the patient on Aspara? 20 minutes or 1 hour?
Most probably we do intradermal test and then review after 15 minutes if there are any reactions, and then to give the infusion with also monitoring with the patients, and mainly during the first 20 minutes the infusion related reactions appear.
So the answer is 20 minutes.
Yes.
Thank
By
you.
maximum the first 20 minutes, most probably in the very beginning of the infusion.
Okay, thank you, doctor. The second question, is there a maximum dose for E. coli asparaginase or Erwinia asparaginase or Oncospar?
The maximum
more
is due to the
clearly.
maximum surface area, which is number 2, surface area 2. So the maximum is based on the surface area, the maximum surface area.
So do we recap? Do we capping those?
Capping based on the surface area also. So for example, the E. coli is 10,000 international unit per meter square. So we do have for the patient with surface area 2, which is the maximum surface area, so we can give 20,000. But the maximum for every thigh is 10,000. Yani we cannot give the 20,000 as a full dose in only one thigh. We separate or we divide the dose into 10,000 and 10,000 in every thigh.
Okay. The other question is, do we have anti-emetic prophylaxis as a preventive measure?
No. It has a low emetogenic property.
A low emetogenic. Okay. So the anti-emetic here is
I haven't experienced the patient suffered emesis from asparaginase actually.
Okay.
Maybe anticipatory due to any other chemo.
So, but I think anticipatory is
very rare if you control
very rare
it from the very beginning.
and low emetogenic. Yes. So with your experience, can you share? Can you tell us about fenofibrate usage in patients with hypertriglyceridemia as the side effects from asparaginase?
Actually, I haven't experienced the patient with hypertriglyceridemia. So I have mentioned just the guidelines. I have experienced only patients with thromboembolism and pancreatitis. And those with pancreatitis, confirmed pancreatitis, we really discontinued asparaginase with them.
Okay, the final question. I will tell you a scenario that the audience tell me. If a patient convert from asparaginase to Erwinia, E. coli asparaginase to Erwinia, what precaution regarding hypersensitivity should I consider?
The pre-medication. So we should give, first of all, the diphenhydramine and the hydrocortisone and the famotidine as a pre-medication prior to the therapy with 30 to 60 minutes. And then to make also an intradermal test, and then to follow any infusion reaction if happened. And not only in the first medication, also in the second, as we have mentioned that maybe in the second exposure, we will find infusion-related reactions or hypersensitivity. So we will follow all the pre-medication instructions before giving even the Erwinia.
Okay. So another question from our audience just now. What is an alternative option to enoxaparin in case patient cannot receive enoxaparin?
Enoxaparin in name, يعني do you mean the subcutaneous or do you want,
Yes.
for example, the oral form of enoxaparin? We do have what is called, I can't remember right now, rivaroxaban, as far as I can remember. So we can give the patient oral form of rivaroxaban.
I think here the enoxaparin regarding the low molecular weight heparin.
In general, not the subcutaneous injection yet.
The subcutaneous mainly.
No, I mean the question, if the question is regarding the subcutaneous route of administration and we want to shift to oral, I have experienced it before with a patient that does not like the subcutaneous.
The
So
question is, what is an alternative option to enoxaparin?
An alternative option, we have given rivaroxaban.
Okay.
Oral, yes.
Okay. So
The question is يعني suspecting aspirin, so no, aspirin has no role.
Okay.
I have covered the يعني two perspectives of the question.
Thank you for your time. Thank you for your patience.
Thank you so much.
Thank you. Now we get to an end to this comprehensive and very fruitful presentation with Dr. Reem. Thank you again.
Thank you.
And nice to have you on board today.
Thank you so much. It was my honor, actually.
Thank you.
Thank you so much. See you soon. Bye-bye.
I want to thank you, Dr. Reem, for your comprehensive and impressive presentation for the event. As well, I want to thank Dr. Mahrouz for moderating the event today. As well, to thank our attendees for staying with us the whole 1 hour and for their Q&A section as well. There were actually very impressive questions that are really into the practice and our daily practice with our patients. So I want to thank everybody, and I want to remind you that you will be granting access to this recorded session in the IVPN library at the IVPN network website. As well, we are going to share a certificate of attendance in the coming 2 to 3 weeks from today. Stay tuned for our second event in March. It's going to be in March 20, and this time it's going to be a unique event in which we're going to talk about some quality issues related to oncology. So stay tuned over our social media accounts on LinkedIn, as well as on Instagram, ivpn.oncology. I want to thank everybody for attending. I want to thank our speaker, our moderator. Thank you for your trust in IVPN Oncology, and have a good day or evening wherever you are. Thank you so much.
Thank you, doctor. Thank you so much.
Thank you, Dr. Reem. It's very honored to have you with us.
It was my honor, actually.
Thank you.
Thank you.
Thank you, Dr. Fatma.
Thank you.
Thank you.